Yeah, good morning, everybody, and thanks a lot for inviting me. So, I think it's a question of high importance. So, what are the unmet clinical needs in bladder cancer, especially metastatic bladder cancer? I think we know that patients and people are getting older, and the incidence and the general burden of metastatic urothelial cancer is increasing in our times. And the mainstay for treatment is currently platinum-based chemotherapy. And what do we know? Platinum-based chemotherapy is effective, but we only have long-term survivors on a 5 to 10% level of cisplatin and carboplatinum-based regimens, even if we have the maintenance regimens and concepts after the induction period of platinum-based chemotherapy. Response rates are there, but they could be higher, and especially long-term survivors are still missing in this situation. And this leads to the question, how can we improve and go beyond the platinum-based chemotherapy for the future? Well, I think if you look back, and it's like 5, 6 years that we had the introduction of the immune checkpoint inhibitors in the metastatic setting of bladder carcinoma, and it's without any doubt that the IO agents definitely improved the outcomes and the survival rates, and also the progression-free survival rates in metastatic bladder carcinoma patients, either after the induction of platinum-based chemotherapy, so the maintenance contact with abilimab, or if they are platinum ineligible, just if a PD positive fraction of patients receiving a checkpoint monotherapy with pembrolizumab or atezolizumab, and of course the second line setting of the checkpoint inhibitors. And I think what we have developed over the past is that we have the mainstay of chemotherapy, that we had the addition of the immune checkpoint inhibitors, but maybe just as a single agent. And now the approach of the EV302 was, well, a totally new design to combine the IO agents here, the pembrolizumab, the PD-1 antibody pembrolizumab, with a specially designed chemotherapy from the antibody-drug conjugate enfortumab vedotin. So what is enfortumab vedotin? It's a Nectin-4 targeting antibody. And Nectin-4 is a cell surface protein which is expressed on the cell surface of the tumor cells. And to this antibody, we have a chemotherapeutic agent which is coupled like the monomethyl auristatin. And by the internalization of the Nectin-4 antibody, the enfortumab vedotin, we have the direct cytotoxic activity of enfortumab vedotin, but we also have bystander effects, and they have an immunogenic cell death, which is provoked by enfortumab vedotin. And the rationale was to combine the ADC plus the checkpoint inhibitor in the phase 3 trial EV302. So what has been done in EV302? It was a phase 3 one-to-one randomized trials. Patients received EV plus pembro in 3-week cycles. EV was given on day 1 and day 2 and day 8, and they had the chemotherapy with either gemcis or gemcarbo as a comparator. And the trial definitely had a positive outcome with 2 dual primary endpoints of progression-free survival and overall survival, which were significantly met. Well, I think as always, if we have new classes of drugs, we have new side effects of special interest. And what is maybe new or what is of importance, we know that immune checkpoint inhibitors can induce a dermatitis. We knew that from EV, that dermatitis is of concern, and in the combination, skin reactions are adverse events of special interest. Another special interest is the neuropathy, the sensoric or sometimes motoric neuropathy, which can develop under EV plus pembro. How shall we manage that? I think first of all, it's of importance to have awareness for these side effects, and that you have an interdisciplinary management. So especially if you gain new experience of this combination. So what can you do? Well, of course, you have the possibility of dose reduction, dose modification, dose interruptions with this agent. And please have an early monitoring for these side effects so that you start treating the side effects once they develop early. And if you start early treatment of the adverse events, then I think you will have a success and that they do not run away and aggravate. Well, I mean, once the metastatic disease is present, it's present, and of course we have the differentiated lymph node positive patients with serum metastasis, but often patients present with metastatic disease. So the question is, how can we prevent the development of metastatic disease? And I think that we have a great development to the perioperative setting, neoadjuvant adjuvant treatment, either in clinical trials of this combination of EV plus Pembro or other ADCs, or as we have observed here at the current EAU Congress, the latest update from the Checkmate 274 trial. This is an adjuvant trial of nivolumab after cystectomy, and we have seen the overall survival data of this trial here at this EAU Congress. That was nivolumab in the adjuvant scenario for 1 year, and the overall survival, it was a descriptive analysis, but the difference between the nivolumab treated arm and the control arm, the placebo treated arm, was very obvious. So the difference was increasing over time, and we had a 10-month improvement in overall survival. I think it was after 3 or 4 years in this trial, which was presented. So start treating early in the adjuvant setting, and I think we can select patients and prevent the development of metastatic disease. On the other hand, this question always relates to biomarkers. What are biomarkers? Well, the field of biomarkers is very wide, but we had a very interesting presentation here from the IMvigor11 trial. IMvigor11 is a trial which has a ctDNA approach. So patients had a ctDNA testing for circulating tumor DNA. If they are positive, they were randomized to adjuvant treatment of atezolizumab versus observational placebo. And they had a ctDNA negative fraction, which was not trial eligible. And here at the Congress, the ctDNA negative patients and their follow-up was presented. And it was very, very interesting that if a patient had a ctDNA negative status, that the risk of developing a relapse of the bladder carcinoma after cystectomy was very, very low. And they learned if the ctDNA was measured over time, if they turned positive from negative to positive ctDNA, that the risk of recurrence is there and increased.